Welcome to our video on the gastrointestinal endoscopy article EMR of laterally spreading lesions around or involving the appendiceal orifice, techniques, risk factors for failure and outcomes of a tertiary referral cohort. We wanted to do this study because the EMR of sessile periappendiceal laterally spreading lesions is technically demanding, and this is mainly due to the poor endoscopic access to the appendiceal lumen and the thin colonic wall at the base of the cecum. Because of this, these lesions are often referred to surgery without an attempt at EMR. So we aim to assess the feasibility and the safety of EMR for periappendiceal laterally spreading lesions. Consecutive lesions over 20 millimeters and periappendiceal laterally spreading lesions over 10 millimeters detected over a number of years at 3 centers were eligible. The standardized technique, which is demonstrated in the associated video, is employed, and each lesion was carefully imaged using high definition white light and narrowband imaging prior to resection. It was important to note with periappendiceal lesions whether or not the lesion extended deeply into the appendiceal orifice. These lesions were referred to surgery. And care was taken throughout the resection attempt with a periappendiceal lesion to determine whether or not this was the case, because if it was, the lesion was referred for surgery and the attempts discontinued. Here are some examples, and a beautiful large lesion around the appendiceal orifice, very nice resection, and then here the scar at first surveillance indicating no evidence of residual or recurrent adenoma. Another lesion requiring forceps avulsion, this cold forceps with adjuvant snare tip soft coagulation for resection, and then a very nice result of the scar at first surveillance with no residual or recurrent adenoma. Just a note to say that it is possible to resect fully circumferential lesions if the patient's had a previous appendicectomy, and we demonstrate some of these and the technique in the paper. And I'd like to show you this video that essentially consists of one of such lesions. So this lesion completely encircles the AO, and you can see that as we progress through the video, sequential inject and resect EMR is how we proceed, and we work from the cut edge of the defect with a thin wire snare, here a Boston captivator snare 10 millimeters in maximum dimension. Towards the end of the resection, you can see that we are working in towards the area of the previous appendiceal orifice, which is sitting here, and towards the end, this is the final piece, and you can see the fibrosis associated with that, and this lesion completely resected and 100% involving the previous appendiceal orifice. These lesions, however, with no prior appendicectomy, that completely encircle a patient's cecum with appendix in situ, are impossible to remove endoscopically, because as you can see here, and in this example, you can see adenoma extending down into the blind-ended lumen of the appendiceal orifice, of the appendix, and these are not possible to remove endoscopically, and should be referred for surgery. So in summary of the results, 38 periappendiceal lesions were removed, and referral for surgery without an attempt at EMR was more likely with periappendiceal lesions as versus standard lesions, 30% versus 5%, and most of the non-attempts at periappendiceal lesions were because of deep extension into the appendiceal lumen, and you should note that 2 out of 11 of the surgical specimens of lesions that extended deeply into the appendiceal orifice contained invasive cancer. However, once attempted, complete clearance of visible adenoma was very common, and adverse events and rates of adenoma recurrence were no different to standard lesions. In addition, 7 patients with a prior appendicectomy achieved complete adenoma clearance, and there were no cases of post-EMR appendicitis. So what does this add to current knowledge? Well, EMR seems to be a safe and effective durable treatment for PA-LSL when you have assessed the lesion, there's no high-risk features for some mucosal invasive cancer, and the appendiceal orifice is less than or equal to 50% involved, and there's no deep invasion into the appendiceal orifice, unless of course the patient's had a prior appendicectomy. These results clearly need validation in larger prospective series, and we'd like to thank the medical nursing team at Westmead Hospital, Sydney, Australia, the host centre, and the other centres of the studies for their help in preparation of this manuscript.